region, avoiding the retromolar pad. So these are my first 2 bits of green stick that I apply. So can you see it's on the outside of the tray there, outside of the tray there. And then I put that back into the warm water, let it soften again, take it to the mouth, seat it onto the gum, and get the patient to perform 2 movements. E, oo, e, oo. That's the first thing. I then add some more green stick to the lingual area here, all the way around. And that goes onto the outside of the tray. It's not on the fitting surface, just on the outside. And it's a thin earthworm amount. I put that on, back into the warm water. Then we take this to the mouth, get the patient to open wide and close, lick their upper lip, push their tongue against the lower front struts here, and then have a swallow. So it's very important movements. It's 6 movements in total. And so once I've done that, I then dry off that fitting surface and then place a thin layer of zinc oxide eugenol impression material on the fitting surface of the tray. It's fantastic. So, and then we take it to the mouth like this. So you notice that Claire's got the retractors in there. It just pulls that lip away on there so I can see what I'm doing. I've got my tray loaded with zinc oxide eugenol, and then I'm going to rotate it in, sit it down, and perform those movements, which are E, oo, whilst holding the tray in, open wide, lick the lip, push the tongue against the strut, the lower front teeth, and then Claire squirts a bit of water in the mouth to do a powerful swallow. So it's 6 movements. Let's watch this video together now. Here we go. Rotate it in. Sit it down firmly. Close up. Now, woo, e, open wide and close. Lick your lip. Lick the lip. Really go for it. Look at Claire with her 3-in-1 tip ready. Push against the strut. Squirt water in. And then have a powerful swallow. It's absolutely fantastic. So you can see that what we're trying to do is to make an impression like this here. So that's the impression there in the mouth, and all of the periphery of the tray, the impression is being molded functionally by the patient, so that denture, when we make the denture, is going to stay as stable as possible during all potential functions that patient is going to do. And these step-by-step techniques were developed by Dr. Arbe, and this is why the lower denture is so stable and why we can often get suction on it. So it now is replicating that in the final. These models, like, we just care for our models. Absolutely. And he pours them beautifully. He retains a land area on this border here, which enables the polished surfaces to be developed. So, and I want to move to the top impression, uppers. I want to have suction on 100% of my upper cases like this. So I'm going to take John's denture out. Look, I can pull and I can just...
So, and then if I just break the seal, I probably
lift the lip there, break the seal, and then that detaches the upper denture like that. So, and I want to share with you techniques of doing this. And I was taught this technique by Professor Fraser McCord at Manchester. He was really a hard guy, but brilliant at dentures. And this is what he said to me when he first saw the quality of work that I was doing 20 years ago, when I just started a master's program in fixed and removable prosthodontics. And basically, Fraser was saying, Finn, you need to get your head into the literature and start learning how to do this properly. And I want to share with you really quickly how we get great suction on an upper denture. So again, it's doing a visit 1 primary impression using my syringe and tray material. So 2-part alginate. And Claire has the retractors in, and I squirt in this material right the way around the labial sulcus, all the way around to the tuberosities, right the way to the back of the mouth like that. So that's first what we do. Second, I have this loaded. This is part of the whole process, loaded with the base alginate. I've glazed it with water. I rotate it in. Patient sitting up. Feet at the back first. Rotate it up like that. And then gently coax it up into the sulcus. Beautiful. The primary impression, specifically to help us produce an impression like this, which then we can then make a special tray to fit. So let's have a look. So we've got all of the periphery, we've got all the way around, beyond the fovea palatini, right the way around the back of the tuberosities. So this is our primary model here. And the design of the special tray is very simple. It's 2 millimeters short of the depth of the sulcus, avoiding the frenum, and we take it beyond the fovea palatini, just onto the soft palate. The tray looks like this. I've got one just here. It's got one handle on it, there like that, and that handle avoids the lip, stays out of the way, and I can just handle it just like this, the tray, just take it to the mouth. Now, the tray's made with a spacer, a wax spacer on top of the primary cast, because I'm going to use alginate. I love alginate for complete upper impressions. They're brilliant for this. Now, before I do the impression, I have to recreate the space using green stick, and that's how I like to do it. It's great. So I add green stick onto the fitting surface along the back here, right on this post down here. So this is on the fitting surface, and also onto the canine points here, as long as these areas are not soft. If it's flabby at the front there or soft, I will apply my green stick stop right onto the palate here. So we take this to the mouth like that, try it in the mouth here. So this shows the buccal sulcus there in about the 5-6 region on the patient. And if the tray bounces into the depth of the sulcus there with my green stick stops on, if it's touching that there, it's overextended. So what I do is I just draw a line on that with a pencil, take it out of the mouth and cut it back and trim it, and then take it back to the mouth and have a look at this space. And please just look here closely now. This is what I'm talking about here. That's the depth of the sulcus. And then we've got a space of 2 millimeters to allow the impression material to flow over and to be border molded by pulling the cheeks and waggling the jaw, etc. So that allows that impression material to do that. Very, very important. So the next step, after placing the stops on the impression tray, is I apply green stick from the canine behind the tuberosity there, and this is on the outside of the tray. So it's like a thick earthworm of alginate placed there and there, and we take that to the mouth there, hold it in place, and I pull the cheek down and do border molding on one side, border molding on the other, and then get them to waggle their jaw with this in place. I'm holding it firmly in place, waggle the jaw, so the coronoid process molds this back edge. And just look at what happens when we do this. So this bit here, which is puckered out to start off with, when we take it out of the mouth, it thins it down. So, and this is border molded beautifully by the patient. This offers the suction effect for the upper denture. So once I've done this, it's not perforated. We leave it like that. I want to check suction on it at the moment, and it should have suction there. So once I'm happy with it, I dry it, apply alginate adhesive all over the tray, and place it onto the buccal shelves on the outside bits, on the buccal surfaces, and then fill that with a really runny mix of alginate like this. And this is Dentsply Blueprint. This is what I love using for this. It records it beautifully. This is runny mix, and then I will glaze it with water, and then we take it to the mouth, just like this. So we've got the patient here, lip retractors in, sitting upright. I've rehearsed all of this before. We always do a dry run with the patient. And the other thing I have is a stopwatch going, so I know how long it's going to take to set. Here we go. Rotate it in. Sit it up at the back first to stop the impression material going down the throat. Rotate it up firmly onto the ridges. Let's look at the front here. So that's it in place. Push it up so it seats fully.
Make sure it's seated nicely. That's
fully
lovely.
onto the
Relax your lips now. I'm just going to
firmly.
just
And then I grip the cheek, mold the cheek,
and relax.
mold it,
And relax.
mold it, trim it underneath the base of the nose.
Okay, waggle
Waggle the jaw.
left.
Coronoid process.
Lovely. And open really wide. And then relax. And then can you suck my finger
Suck the finger.
as hard as you can?
It's very important. Look at the
And
modiolus
relax.
there. Very important that there. And this helps to get really great suction on the denture. Look at this in the mouth. Now, how this is the border of the tray, and then this is the molded portion here. It's beautiful. And this helps us to get this peripheral seal. And so what I'm looking for when I take the impression out is I want to see the green stick pushed through. These are my stops here. You can see it pushed right through, and then all of this border molding is just beautiful here. And then Rowan carefully replicates this there and pours it beautifully, preserving the land area, and then produces a denture that just fits that perfectly. It's fantastic. So that is the impression making, and I think the impression making part is the most important from a functional perspective for the whole thing. I want to now move on to talk about tooth positions. This is the artistic part of it, and I love this bit particularly, because what I'm trying to do with my dentures is quite simply is to replace the teeth that are missing, and I want to put the teeth back where they actually would have been if the patient had them. So if they were class 1, that's what I want to do. If they're class 2, division 1 with a big overjet, that's where we position them. If they're class 2, division 2 with a deep overbite and these butterflied laterals, that's what we do. And if they're class 3, that's what we do. And not only do they look great, they function superbly because the teeth are in the zone of minimal conflict, the neutral zone. So let's move to now visit 3, jaw registration stage. So now, generally, I feel that these are superb for registering the occlusion. And I think these are called Manchester rims. They were developed by Fraser McCord. And it's an upper conventional wax block, but the lower is a pivot here. It's got 2 blocks on it. And these are made specifically like this. So you've got a pivot there, and it's made of a light cure base with a rim and 2 holes in, so that can allow this wax block, this little wax block, just to stick on there. Now, these are fantastic because it really helps to marry up the upper and the lower together very easily. So if you imagine you've got a patient in the chair and you're not doing your normal wax block jaw registration, trying to get the lower to marry up to the upper and preventing it from tipping and coming away from the base is really quite difficult. This avoids that totally. It's really, really good. So I'll talk you through the steps here. So this is Henry here. What I want to do is I really want to have a superb picture of Henry here. This is on his wedding day here with his smiling nicely. This is Henry in his 90s here. And I want to carve that wax rim and having this dentate picture, even though it's years ago, it really helps. It's absolutely fantastic. So this is Claire and I, and this is us doing the a wax jaw registration. And what we do is, for this, I have a photograph. This is Julie here. And I've got a photograph of Julie with a natural dentition on the picture there. And I want to get a mental picture of what Julie would look like if she had her natural teeth. Both Claire and I, this is my dental nurse who's worked with me for 13 years as Claire, we both participate, and it's like a team approach at this visit. So I keep putting it in and out, and we both look at the patient. Claire's got a great eye for knowing whether we've got everything correct. And this is what we do. It's a recipe, really simple recipe, is I do the lip support first, incisal plane, occlusal plane, buccal corridors and centerline. It's just a little recipe. So it's lip support first, carve and I want this upper rim that Rowan gives me to be big, so I can carve that back. Lip support first. Number 2, incisal plane with reference to the interpupillary line, and we match that up if the patient wants it to be matched like that. If they had a cant with their natural dentition and they want to have that, we reproduce that. So number 2, incisal plane. Number 3, this is critical, occlusal plane. The occlusal plane, I want it to be parallel to the alar tragus line. So if you imagine, you can see the tragus of the ear here. I want the occlusal plane to be parallel to this. And this is crucial for great aesthetics. Really important is carving that. And the way that I carve it, I have a Bunsen burner going, and then a wallpaper scraper from a hardware store, and I just heat that up in the Bunsen and then hold the wax rim against that and just carve it down and to get it parallel. Number 4 and 5 steps are the buccal corridor. So I'm looking at the buccal corridor on the photo, dentate picture here, just like this for there and there. And then also I put another line on, which is the center line. So that's step 4 and 5. And so that's the upper rim done. I then take the lower pivot and I get the occlusal vertical dimension right at this point. So I trim down the lower pivot here. So trim that down, pop it into the mouth, and both Claire and I look at the patient, and when we think the patient looks right, just like Anne here, at that vertical dimension, that's what we go with. So it's a bit like John Coyce talks about, if the patient's vertical looks right, they are right. That's how we do it. So once we're happy with that, I then make sure that the patient is biting nice and evenly in centric relation by putting 2 lines on. So one line on the top, one line on the bottom. Get the patient to just relax the jaw, curl their tongue back and close together. And I want the lines to marry up. Once I'm happy I've done that, I cut a groove in the upper like this, and then I fix it together with Futard D. This is Futard D bite registration material, like that. So that's it. That's the registration done. I then take this out, and this is another detail that is fantastic. I separate those like that. I then get a bite fork on a faced bow, squirt some Futard D onto that, place my carved wax rim onto the face bow, put that into the mouth like that, and then I do my face bow. I use the Danar system, but any face bow is great. You know, one of these good quality articulator systems will do perfectly for this. So this is what Rowan gets. He gets the jaw edge here, which that all fits together there. And also he gets this. This is for the face bow. So quite simply, Rowan mounts this like this. So the face bow gets mounted on the articulator like that. I've actually got one here just from the practice there. So it just gets mounted there. The upper cast gets mounted to the upper member. Rowan takes the face bow off and then attaches the lower to the upper and then fixes it together just like that. So we've got the patient's head on the bench, you know, ready to then set the teeth up like this, there. So now the other thing that is crucial to getting great aesthetics is to give Rowan this photograph at the end of visit 3. So he needs to have both the dentate photograph and also the carved wax rim. And then Rowan then uses this wax rim as a matrix to set the teeth up. But just look at what we can do with a complete denture. Look at this. And the skill of Rowan in doing that is just amazing. So, and this is like longer teeth. Rowan's added to the teeth. We've got some black triangles. We've got lovely skinny gums too, and they're gum coloured. So we really want to fool people into thinking, gosh, Anne, you're so lucky to have kept your teeth throughout your life. It's really, really important, this. So now, how do we select the right size of teeth? So if you imagine that we've got Jen here on the right-hand side, she's sitting in the chair, and she's also brought in this lovely picture of her dentate at her wedding day. and we use a formula which has been developed by John Besford years ago. And this formula is really quite straightforward. And it's the basis is that the interpupillary distance here from the age of 8 upwards remains static throughout our life. So we can measure, we have the patient in the chair, so we can actually measure this interpupillary distance there. We've got the photograph, which we can enlarge and put onto a screen. So that's the IPD of the photographic PD. We've got the upper central incisors. We can measure that. Plug this into this formula here, and it helps us to calculate the size, the width of the upper central incisors. So for Jen here, her upper central incisors were 8.4 millimeters. It's fantastic. And then from this, we can then look at selecting the right shape. And what we do is we take 3 of the same size teeth and then try to look at the shapes that correspond with the shape of the tooth from the photo, just like that. So, and generally it's 3 that we have to choose from. And it's just Rowan and I do this. We don't get the patient involved at this stage because it's very difficult for the patient to know which one they like out of those. We chose this one for Jen, and it's using the Enigma Life guide here. So if you have this in the surgery, you can actually select. They've got all of the measurements on here and all of the different molds, so you can actually look at all of these and select the right size of tooth from that. So here we go, and this is what the difference that we can make, you know, with looking at, so Jen here with lovely buccal corridors there, lovely curves following the lower lip there. It's great. And being brave with tooth positions. Rowan's been brave, you know, like Bert's here. Look at this is his lower denture on the left-hand side, and look at it in the mouth there. We've made the lower teeth wonky here with little bits of staining in the top there. We can do it as much or as little as you like, but a little bit of imbrication just stops it from looking like a denture. Brilliant. So now the next thing I think is really important is this. I do a video at the try-in because I want to avoid a patient coming back after the dentures have been fitted and telling me they don't like the look of the teeth. So, and this is the next patient I want to show you, which is Diane here. So she presented like this. So she had this made as an immediate denture, and then this one as a second denture, which was much more comfortable, but she was unhappy with the aesthetics. She wanted to have this natural appearance back. So she had, like, you know, really very much a class 2 division 1 anterior open bite even. So this was Diane at the try-in video, and the try-in videos are dead important. What we do is we get Claire films the patient on a tripod and just talks and engages with the patient socially, gets them smiling, laughing, talking, thinking about, you know, where did you go on holiday? What books have you been reading? What have you been watching on telly? Socially engaged. Now, and it really helps the patient to really look at themselves properly, what they're going to look like. Now, Diane hated this aesthetic appearance. This was the try-in wax. She hated it. And she said, I look dead with this in place. And she said to me, look, when I walk down the high street in Garstang, where we live, people think I'm smiling when I'm just my mouth's at rest. So she had an incompetent lips, But this didn't do that for her. She wanted the teeth bringing further forward and up. So this is we went to a second try-in. So Rowan reset the teeth, and we repositioned the teeth further forward and also up a little bit, almost like a V-shaped aesthetic. And she loved it immediately. And she also came in for this visit with her husband, Peter, who also had a really great eye for detail. He could remember Diane's teeth beautifully. And so they sat together, looked at the video and said, yeah, we love it. Let's go with that. And so this is our original try-in one, which Diane thought looked dead. This is the second one, which she really loved now. And it replicated that AOB that she used to have. You know, it's a V-shaped maxilla. And Rowan's really brave with this setting up of the teeth. Look at this, full upper there. Huge overjet, big AOB there in this case. Look at that. And so her occlusion is actually on that tooth there, and it's clear all the way further forward. And this functions beautifully for her in centric. So I'm going to pull everything together now into finish this presentation just really quickly with Anne, who's a full case. That this is how Anne presented. She's actually the most difficult full case I have ever treated in terms of the lower and the lower support. Let's have a look in the mouth now. Now Anne she used to have 4 implants in the mandible here. So she used to have a fixed lower hybrid beam here that had failed. And at my consultation visit, this is how much she jumped when I was palpating the ridge. Just watch her. This is at the consult. Look at her jump. And I couldn't get a gloved finger, and just even resting my gloved finger was excruciating for her. It was just a nightmare in terms of support. So at the consultation visit, I got Rowan to come through, and we drew a diagram of the lower, and this is in green, is where the denture itself, where we could actually place pressure. And then everywhere else, it was impossible. It was just jumping. It was excruciating. So I got her through and had a chat with her and said, look, I don't know what I can do for you, because I'm not even sure we're going to make you a lower denture that's going to work. And I said to her, I just think that the fixed is really the only sensible option for you. And if we do a denture on this with a soft lining denture, I'm only 30% sure that we're going to get it comfortable. And I reckon that we're going to always have some discomfort for you. So now in these really tricky cases, and I do a slightly different approach than what I've just shown you now in terms of the occlusion. I do a Gothic arch tracing for these patients, which is very, very important. In fact, I use Gothic arch all the time for my complete dentures because it's so accurate in getting centric relation and getting an even bite. In these particular cases like this, an even bite in CR is crucial, as well as great impressions. So if you notice, we have a primary registration here at visit 2 there, as well as our normal registration stage at visit 3. This will become clear in a minute. So visit 1, exactly like I've shown you today. Visit 2, definitive impressions in just the same way that I showed you, but rather than using zinc oxide in the lower, I used alginate just because it was softer, so I could actually do an impression for her. Visit 2, I do a primary jaw registration as well, using, these are rough pivots here. So this is a primary jaw edge, and this goes into the mouth. I carve that to the correct vertical dimension. So this is the primary rim in the mouth at the correct occlusal vertical dimension, and then fix that together. And then this enables Rowan to mount the definitive models using the primary jaw registration to set up a Gothic arch tracing on this. So this means that that is going to be parallel when I take it to the mouth. Very, very important. So here we go. This is visit 3. So I've got the Gothic arch tracing system there. These are all made on the definitive models, and we've got a new, our proper wax block, lower pivot for prescribing the tooth position, and OVD perfectly. So this is what I do. I carve the upper rim using, with reference to the dentate pictures in all of the steps that I show you. And so it's lip support, incisal plane, occlusal plane, buccal corridors, center line at the correct OVD. And then I then take the Gothic arch, which I set to that OVD that we've got here, and then we can take this to the mouth to record centric relation perfectly. And this is awesome. I love it. This is a Swiss system, a Gerber condylator system. You can download this from my website. So I put a mark on here, China graph. I take this to the mouth and then get the patient to go forwards and backwards. That pin is the only contact between the upper and the lower,
and then go side to side,
just like this here. Forwards and back, side to side. And the patient is making an arrow on here, making the Gothic arch. It's brilliant. I love it. So on the plate itself, we will get this, and that there is centric relation. Bang on. We can put the plastic disc on, screw it down so it's nice and firm and solid. Take that back to the mouth, guide Nancy back into the hole there, and then I squirt in Futard D bite registration material. Fix that together beautifully, and off we go. And we know we've got centric relation. And then this gets mounted onto the articulator. So the upper definitive model is mounted using a face bow transfer of the carved wax rim. We take that off. The lower is fitted, the definitive cast on the lower is fitted to the upper model using the Gothic arch tracing. And then there we have Anne's head on the bench, ready to set her teeth up. Those lovely butterfly laterals. It's fantastic. So here we've got it. And secondly, we have, importantly, a Moloplast B soft lining here, there. So let's just look at the denture. This is what she came in with. So, and that's got a Moloplast B lining. But look at this snowshoe principle, maximizing the denture bearing area like that here. So that's what we made for her, for the lower. Turn it round. That's the soft lining material. I've got one here. It's just, you can just feel it. It's just lovely. It's got a little bit of resiliency to it. Now, getting this comfortable is really tricky here. So, and so I take this. So if you imagine now we're at visit 5 and we're fitting this. So we've got the denture there. Now, if I try that in and press it down, it hurts. So what I do is I say to Anne, you know, whereabouts is it sore? And she'll point to it, and it'll be a rough area, but point somewhere near it. And then I put Vaseline onto the moloplast, a little very thin layer of Vaseline, squirt some silicone crown and bridge impression material, some light-bodied impression material, take that to the mouth, press it down firmly onto the ridge, let it set, take it out, and then where it pokes through, where it was sore, I use a pen or a pencil on here, like a Sharpie. We disinfect it, use a Sharpie there, peel it off, and then using a moloplast trimming burr, cut that away. So that, cut it away, and then repeat, rinse and repeat over and over until the patient feels it's comfortable. And then she can then go and use it. And that's how we do that in terms of getting it comfy. So here she is as she presented. Now this is like your almost your British standard denture with the teeth too far back, but to give them a bit of show, they've been brought down. So we need to bring them out and up. Watch what happens. We change this to that there. Just totally changes the look of her face. And just a little bit of butterfly laterals. They're a little bit too light for her probably, but some patients, we give the patient exactly what they want aesthetically. And so this is how long it took me to do this for her. So we spent 13.5 hours with all the reviews, etc. afterwards. It took Rowan 15 hours making the teeth. That was the fee that we charged her for her dentures. And I just want to share with you just now, I've done over the past 13 years, I've got a really small referral practice. We see very low volumes of patients, but we spend a lot of time with them. So in that 13 years, I've treated that number of complete denture patients, and none, hand on heart, so far have requested dental implants. I'm sure there will be someone in the pipeline that will come back and need them, but Anne was fine with this. Thank you very, very much for spending the time with me. It's been lovely, but it's been great. Now, so what I'm going to do now is I'm going to spend about half an hour. I'll be looking through the questions that you've been asking. So just to remind you though, if you want the handouts, because this lecture's on there, the materials are on there, the construction manual's on there, just go to that page and scroll down and download those PDFs. So what I'm going to do now is I'm going to just stop sharing my screen and come back to the meeting here, and I'm going to have a good look at all these questions. So I'm going to just go to a full screen there and go to chat. Bear with me, I'm just doing this on my own today. That's lovely. So let's have a look. I'm going to go back to front. So that's really good. So let's have a look at, so Sai Lee, hi there, says, thanks Dr. Sutton, that was a great webinar. Could I ask, why do you need to add green stick stops in the canine areas for upper master impressions? So the important thing is this, the upper tray, and the reason is it's been made with a wax spacer, which is one layer of wax, which is about 1.5 millimeters. I want to recreate that layer of wax or that space. So it's important I have it both at the front and also at the back to have an even layer of space. Very important. And those green stick stops are just brilliant because once I've done them, I can actually go to the patient's mouth, sit it in the mouth, and I could do the impression blind without even having to. I could just shut my eyes and just do all of that moulding and know it's in the right place. Inspired. I can't wait to go back to work, Ros says, and do dentures. Excellent. That's great. Lovely. That's great. So here, melee. After lots of ridge resorption, how can you set the teeth on the middle of the ridge? So this is very, very important. So in the upper arch, because of resorption patterns, the upper ridge shrinks inwards like that once the teeth have been extracted. So all of the upper teeth must go on the outside of the ridge. So, and that's why I need to carve that upper rim. It's very important. Now, lower teeth, they essentially, particularly the lower front teeth, they go over the top of the ridge. So the necks of the teeth sit vertically on the So we put the necks of the lower teeth on the ridge. But when this is a really important detail though. The second thing I'm going to say is the lower teeth at the back we set onto the pound line. The pound line is a line just outside on the labial of the lower ridge, so that the center of the middle of these teeth are set right over the pound line. In other words, it gives the tongue a little bit more space just to sit. And denture teeth are not as wide as natural teeth anyway, so the buccal edge is on the same position, or approximately the same position as where their natural teeth would have been anyway. So the pound line, Earl Pound, flipping brilliant. His techniques, Jack Turbyfill in America, the really good way of setting up the lower back teeth. Superb. Let's have a look there. So that's great. So Haziri Binti Yusuf, how does the technician